No, we're ready for discussion. Yes. Director Gallagher? Here. Julie Peterson? Here. Jessica Dixon? Here. And Chair Pimentel? Here. Not aside from the two supplements, I can add the budget and the fire marshal. What comments do we have? Have hands raised online, maybe a hair louder. You do have a mic right there, but.
Sure. For any public comments, this is a time for any members of the public or attendees to speak up on things not on today's agenda. Do we have any members of the public? Their hands raised online.
No hands online.
Anybody in person? None. Move on, close public comment, and move on to comments from committee members. Similar opportunity for committee members just to share their comments about anything. Seeing none, we'll move into today's action items on consent. We have one item on consent for our minutes for August 26th. In the packet, do I have a motion to approve? Thank you. Very efficient.
So I'll take a roll on this item. Director Gallagher, yes. Julie Peterson, yes. Jessica Dixon, and Chair Pimentel.
Yes. Item number 2 in our, we have 3 items in our discussion. Item number 2 is our Wausau Hospital Finance and Audit Committee removals and appointments. Do we have a presentation or discussion from staff or otherwise?
There's not a presentation.
Yes.
As you guys know, Matco has left Watsonville Community Hospital, so we want to obviously thank him,
yes.
Even though he's not here, thank you for absentia, and formally excuse him from this committee, and bring forth Mike Russell, who's our new Director of Revenue Cycle, and his resume, I believe, was in the packet, and we would like to forward that to this committee, and then if this committee agrees, pass a motion to forward that to the board for approval of Mike as our newest member.
Any questions from board members? Public? For public comment on this action item, any hands raised online?
No hands online.
Any comments? Closing attendance? Any final questions before we consider the action? I know that, I do agree with you, Julie. I think Matco for his tenure and serving on the committee, is a valuable member and a valuable part of our community, and I'm thankful that he's still part of our community, working in this community, helping our healthcare community. I've met and talked to Ms. Russell Mike a few times, and really impressed, and I think he's a great asset to our team. So thank you for bringing this forward. We have a motion to approve and pass recommendation. I move approval, and then we forward to the board.
Second that.
Thank you. I'll take roll on this item. Director Gallagher?
Yes.
Julie Peterson?
Yes.
Jessica Dixon? Yes. And Chair Pimentel?
Yes. And number 3 is our financial performance of August 2025, and that's
Rosie, pull up. Okay, so the month of August, we have a EBITDA loss of $2.6 million and a net loss of 2.7, almost 2.8 million. I do want to point out that this was a month where we did a accounts receivable methodology change that was almost $1.9 million to our bad debt, just changing our reserve methodology for accounts receivable that is over 365 days old but less than 730. Historically, this organization has been still assuming some collectability, about 90% reserved, about 10% collectability, and that last year we do still collect on some revenue. We now have besides our self-pay vendor, we also have another collection vendor that will continue to work accounts, but we decided it's pretty much an industry standard generally to reserve at 100% once something is more than a year. So we decided this was a good time. It kind of helps clean things up for us to make that change. But unfortunately, that means you take that 10% of a lot of older accounts and you move that to your bad debt line on your income statement. So that is, a major piece of the $2.6 million EBITDA loss. You can see that, without that, the month would have been a little bit better than the last few months we've seen. It still would have had a loss. We're still impacted by lower volumes, lower to budget. Some of that is known because, as we've talked previously, we did not do the pediatric admission program that we were planning. We've seen softer inpatient volumes. We've seen even softer ED visits than we had planned for. And, of course, we have not, fully utilized the cath lab to the extent that was in the budget. So, you can see here that the major swing for the month is in the net revenue at $4.5 million below budget, with almost $2 million of that being this bad debt transaction. On the expense side, the expenses generally are favorable to the fixed budget, not quite so favorable when you flex for the volume, but we are seeing some improvements in the volume flexing in some of our departments. In any given month, some are able to flex a little bit more, or their volumes are up a little bit better, so that they don't have to do as much flexing, and then other departments just kind of like the numbers don't always line up right, and with staffing ratios, you can either be at an ideal census for a staffing ratio or one that's not so ideal. So we've got a little bit of everything going on there. We also have, our professional fees is generally the area where you can see us unfavorable for the month. Got our new radiology group on board now. We've just brought in kind of our new other half of the hospitalist group after we lost USACs earlier in the year. We had Kaiser covering the whole house for the last 7-8 months, and now we have Dr. Hazrati's group, M-Care, that started in the middle of September, and then Kaiser's going back to having half, and M-Care will have the other half. Next slide. So on a year-to-date basis, you can see that we're sitting at about $13 million unfavorable EBITDA, and a net loss of almost $14 million. And it's really the same story. You can see that, $22 million of that is in net operating revenue. I'll talk about that a little bit in the next slide. And that most of the expenses on a fixed basis were about $7 million favorable to budget. And, some of that, of course, would erode away with the lower volumes. Slide. So this is a picture that I've shown you the last few months. I did add in a new sliver for this month because of that bad debt transaction and the fact that about 9% of this month's variance, and this is really a year-to-date variance, but about 9% is related to the bad debt transaction. And as has been the case, most of the other things are, fairly even. Volume is a little bit heavier here, probably somewhat offset because of this bad debt, because, really the bad debt it's a collections, but it's not really in the same time period. That's why I wanted to kind of split it out and not show it as a collections deficit. We do have, variances there. Very challenging sometimes to tease out how much of it is just something you haven't yet collected on to the extent you expected, versus it's a payer mix shift, it's a service mix shift where what we budgeted planned for a different level of service or payer than what we're actually seeing. So, there's a little science and a lot of art here. Yeah. I was going to say one other comment. I did kind of drill in a little bit, just from the volume perspective, looking at, what were the numbers showing us. And, on the inpatient side, we've definitely seen, the lower medical inpatients down. While we've had strong delivery volume and OB volume for the most part, between lower length of stay or just lower charges in general, we've seen, that's had an impact, and then some of the inpatient surgeries. I think some of the lower charges also could be related to some of the charge master adjustments that we did last year when we were looking in our budget, just trying to make sure that all the charges made sense, were competitive with our peer hospitals, and they were kind of more in line with how our payers pay us. The outpatient side, we've been overall seeing an increase, even though we've seen a little bit down in ER and down somewhat in surgeries. But, I think the biggest challenge that presents us when we think about this is that the reimbursement rate, kind of the overall collectability on an inpatient account, is a higher percentage than on an outpatient account. So it would behoove us if we could grow a little bit more inpatient volume, as long as we do manage well to length of stay, and as long as we're managing our staffing and our expenses well, there's generally stronger reimbursement there. Next slide. So stat-wise, you can see that, we were almost 19% unfavorable to budget and admissions. A good portion of that, not all of it, but a portion of that would be the fact that we had budgeted for pediatric admissions and then put a pause on that program. Our patient days, our length of stay at 3.12 is pretty low, and so that really shows in the patient day variance. It's off by 17%. Deliveries, it was one of those strong delivery months at 87 deliveries. They seem to pop up every 4 months or so. We have a real strong month, and then we kind of go back to our norm of, high 60s, low 70s. Inpatient surgeries were pretty close to budget. Outpatient surgeries, we were down by 36. A good portion of that would have been the cath lab surgeries that we budgeted for. We're also a little light these days on ortho and podiatry, mainly for the lack of physicians in that area. We have our new ortho that's scheduled to start around December, and we do have a podiatrist that's been out on a medical leave. Next slide. Year-to-date, and I think one of the things about this year-to-date slide, some of this will come back when we talk about budget in our next agenda item, but it's very similar to what we've talked about in the monthlies, with admissions being down about 14%, lower length of stay, and CMI, or the case mix index, being a bit lower than what we had planned for, and the one thing that has kind of hit budget all year long has been the deliveries, and then, of course, our non-emergency room outpatient volume has been strong and continues to be pretty strong. Slide. So admissions. On the inpatient side, it was a stronger payer mix month. We actually had a strong month on the commercial with 17.2% commercial, and our Medicare was up 2.2%. which means the ones going down were the ones with lower reimbursement, the Medi-Cal, the self-pay, and managed Medi-Cal. So that was strong. On the next slide, it wasn't quite the same story on the outpatient. We actually saw a less favorable month on outpatient because we had 23% in the ED, but that was down almost 2%. And between our Medicare and our managed Medicare, we were down another 2%, with the pickup mainly being in the Medi-Cal and managed Medi-Cal payers. So with that, I will stop and take any questions.
I want to ask, without the AR write-down, we would have had a better month or loss, better than what we've seen. Is there anything in our volume that says for October or November that we're seeing some stable volume come back, or is this fluctuation?
It's a fluctuation. I mean, the September volumes haven't been as strong as the August ones, where August was kind of a nice bounce back because July had been extremely low in kind of what we're used to. I think, as we get a new ortho doc coming in, really leading us into 26, but, that should bring in some volume because we've kind of had a hole there in the schedule. There's certainly, with all the work we're doing with Measure N dollars to, start the construction on our CT and our MRI, that's going to give us, the ability for more volume as well as the efficiency in better tools. There's been some great fundraising that's going on around things for our OR rooms, to upgrade OR rooms, and, that should attract some new volume. That's more of a 26 line item. So, it's like, it's a bit of a lull in a plan that has a lot of go-forwards in the future, because we have the Measure N dollars, we have grant money, and other philanthropy donations that are all giving us the ability to build for some of the services we want. And then, of course, we've still got to make that connection with physicians and patients to actually materialize.
I have a reference, probably a question for Steve and other people not in this room, but what might it take to get volume in terms of working with providers in our community to model their patient care?
It needs a stable staffing and clinical training program that Kirsten Palmquist, our advanced director, is now taking over that piece of it, and that will give the physician the confidence that the clinical care 5 days a week predictable way. So that's what's being right now. I think what we got to was kind of phase one of like, let's get it licensed, let's get all the things in place. We have a couple of really great travel nurses that kind of helped us get to that point. Now it's next phase, which has clinical expertise. We're heading that up and looking further.
I appreciate it was a reminder that the more we can do is bring more inpatient
feel good that, you know, overall surgeries have, you know, stayed where they should be. I mean, if you take the cath lab out, if we hadn't budgeted for the cath lab, we'd pretty much be close to our surgery budget, even with the absence of some physicians. And we've been doing that based on older equipment and, you know, sometimes challenges with anesthesiology or things like that. So it says a lot about our surgical program, and we have good outcomes that, you know, if we're able to build and get some new towers and lights and things in the OR, that's going to attract physicians or, you know, and we'll have the service here for our patients and we won't have to be sending them somewhere else. So I feel good about the surgeries. You know, I think the admissions, you know, are just really important to us because, you know, you have to, that core staffing. You have to staff for, you know, kind of the, at least the bare minimum, and the, you know, when it's lower, the bare minimum is a heavier load on the hospital than is. You grow some volume, you get more efficiencies there. And so, especially inpatient surgeries can then lead to, you know, higher census on the unit. You know, there's just the unknowns. You know, I think one of the biggest unknowns for us is in the emergency room. We know we're going to be busy. You know, we always are. We know we're going to continue to be busy. We hope we don't see too much of a payer mix erosion as things come out of the HR1 bill. We also sometimes just don't know if some of the volume fluctuation is due to other fears. So it's, you know, we're working with some of our partners, like our self-pay vendor that also does the eligibility for new enrollees. I asked them last week if there would be a way going forward to try to capture, you know, people that we will refer any self-pay patient to them to see if they can help get, you know, coverage. And so I said, will there be a way for us to say, to kind of say, like, in the old world, pre-HR1, this person would have qualified, but in the new world, they don't. We could capture those kind of metrics and or, you know, just anything that helps us explain if we see kind of a deterioration in volume that would tie it back to the bill. So that's, you know, I don't know exactly how that'll come about, but they are going to at least look at different, you know, reason codes and things that they put into their tools. And they're also studying these bills and willing to do education for us and help, you know, in any of the conversations they have directly with patients as well.
I'm helping to frame this right context. Because that'll come very unfiltered. Our federal government, the latest thing is risk of a federal shutdown. Medi-Cal, Medicaid is the program that comes with an effort, and they should be back to it. Are there any other federal revenue streams that you might be, or that our associations are saying, if there is a shutdown or a prolonged 3 weeks, 4 weeks before, is there anything that we're being alerted to for associations that are careful with this? The county, we're getting a lot of that right now. We're starting to ramp up with what if scenarios. 2018 was a long one. That's extreme. I would hope pretty much like golfing, another place called flu. We weren't. Healthcare just generally isn't as directly impacted. That has historically been.
Yeah. And, you know, since most of our Medi-Cal business is coming through the Alliance, you know, just our true fee-for-service Medi-Cal portion is a lot smaller.
Will we still often purchase, you know,
If they don't already have it, like if they were a new time mom. you know, I don't look at any statistics specific to that,
Sure.
but certainly a good portion of our OB business at Cal.
Agreeing with it, I appreciate you asking about making sure self-pay are understanding their ability to become enrolled coverage. We work, like the county has a strong benefits rep group in human services department. Their primary job is to help make sure
That's the vendor is called Elevate, and so anybody who comes in, without insurance, they are referred to our eligibility vendor, Elevate. They make contact with them. And we will mention this or talk about this during the registration process, but, you know, their main contact is gonna come through the vendor. They'll make multiple attempts, you know, to make contact. They're pretty successful at contact, but that is one thing that I've asked them to kind of, you know, keep an eye on if people, you know, that have fears might, you know, no, I don't know who they are, I don't wanna talk to them, you know, so we're gonna watch for any kind of, because I thought when I looked at this month's numbers or last couple months, I thought, you know, maybe I'm starting to see a little bit of an upward trend of non-responsiveness, but, a little too early to tell there, but generally they make contact. They may still have people that say thanks but no thanks, and then they go through, you know, can we set you up with a payment plan, or if they do go through the qualification process and for some reason don't qualify, then they would still try to set them up with a payment plan, try to work, you know, they work them for about 6 months, and then if they're not successful and they haven't set them up on a payment plan, they return the accounts to us and we send them to the next vendor. And they will work them for a good portion of the time.
I think this is the last one. You mentioned about flexing. Are there things within our bargaining or union contracts that stop us from flexing to the full, and we have a minimum staff position, or is that a question for another?
Well, we have staffing ratios, you know, in nursing,
Yeah.
the state ratios. And then in pretty much every department, you have kind of like your safety, you know, core safety, like this.
Sure.
You know, if I'm doing HBO, I need an HBO tech, you know. But there's not a lot of things, I mean, it's a lot of times with flexing, and, you know, it's different at different hospitals, depending on, you know, either where they've tended to operate or, you know, I've been at some places where kind of the word from high says, this is what you get, make it work, kind of thing. You know, so we call those labor standards, you know, and how many, you know, like when you do a staffing grid, how many CNAs do you get, how many patients before you get another CNA, or how many patients, just like we do with nursing. So we kind of try to create our own, what we call core staffing.
We have a lot of them within our industry, within our hospitals. Thank you.
Yeah, you know, I mean, I think where we try to look at things is, if there's a core set of staffing needed for every kind of service we offer, do we have enough patient throughput 5 days a week, you know, 8 hours a day, 4 hours a day, 12 hours a day? What is the right hours to be open for the staffing and the patient demand that we have? Trying to.
Is there any other questions? Hand raised. Do we have anybody from the public that?
Thank you.
This is always very informative, very thorough, very transparent, and I appreciate how well you deliver challenging news.
I appreciate how well you take it.
I could not have said that better.
There's a buffer between opening the packet. If I know that. All right, item number 4 is our 2026 budget update.
I'll tee this up. You've met Vanessa, our Director of Finance, Planning and Analysis. And so she's going to do the budget update today because her and our small financial analyst team have been working furiously on a very detailed budget. It's an in-progress point report out. The numbers that you're going to see are not the numbers that are going to end up being our budget. There's still a lot of work here, but we did want to give you a kind of a snapshot of where things are at.
Okay, so the next slide. So like Julie mentioned, detailed work is still in progress. We're going to focus really just on the methodology and kind of assumptions, high level, and then present some preliminary budget numbers. So everything's based on volume. So that's kind of the standard in which we kind of project expenses and project volume or project expenses and revenue. So a really detailed look at data starting at 1/1/2022 year to date. We use that to kind of project what the completion of 25 will be, then use that to get to projected 26. Within that mass of data, we look at seasonality, we look at trends year over year. We also look at emerging volumes and see, history is past, but what is emerging as well, putting kind of a little bit more weight to that, and you'll see how that kind of comes out. We then present this to ELT. They have discussions where they kind of project what they believe the census growth will be and the trends for kind of at a high level for 2026. That's focusing on IP volume, admissions, days, surgical volumes, outpatients, deliveries, and observations. So that we take those high-level volumes, we then look at a historical utilization, and then use that to determine kind of the 2026 department-specific volume, so that it's a trickling effect, that if we see lulls and highs in census, we also see that in the corresponding ancillary and whatnot. So this is kind of the standard, our anchor stats is kind of what we call it, is what we use to kind of drive revenue and expenses for a projection.
And I'll just make a quick comment that given, we usually do that first volume, high-level volume projection in about June, early June. And because of what we saw in June and July, we redid it after July and pulled back some of the volume because we saw such a drop-off.
Julie basically kicked it off in terms of, you look at the volumes on the next slide. We had a better basis in terms of what we thought 2026 will look like, but based on kind of looking Q1 versus Q2, things weren't looking very good. So we kind of wanted to put more weight on our emerging volumes rather than historical. So you'll see here that where we land for 25 and where we'll be for 26 is projections of 10% declines in admissions discharges, days accordingly, and then kind of a pickup, luckily, in OP visits. ED, we kind of project a slight decline there. And then we're hopeful for surgery cases, kind of to what Julie highlighted earlier about bringing on new providers. So we'll get to that after the fact. And again, deliveries has always been strong. And observation of products of admissions and ED, so we're expecting a decline there as well. So I think we're just kind of go through this quickly. Like I said, we kind of anchor on those high-level volumes. We then kind of look at what is the supporting volume within each department, kind of understanding the breakout between inpatient and outpatient, understanding what's the observed average number of services per IP or OP visit respectively. We then use that to apply it to the department staff, and that becomes kind of the unit of measure that we use to project revenue and expenses. So those will drive, obviously, labor and supplies predominantly. Provide an example of how we do that. So you'll see at the top bar, we have the number of patient days, OP visits, and admissions. So for a department like pharmacy services, we observed that 13.4 scripts were provided each patient day, and then correspondingly about 1.5 units per OP visit. So we use that to get the sum product to kind of say, here's what we believe the total units are for a pharmacy. Do the same exercise for a lab, clinical lab. And again, for departments like radiology, we have also observed how many services are there per admission, and then kind of what proportion of visit is, a radiology service provided or ultrasounders. So we're really trying to make sure that our high-level volumes kind of feed into our support, that it all kind of makes sense when you look at the budget in totality. Right, so base revenue. So here we basically looked at, 2024, what we are projecting for 2025, and then what we have for 2026. So like I said, our methodology is to look at the volumes, look at kind of what the revenue per volume is, and kind of project that forward. Within the revenue charges, we're assuming a 3% increase. We're very strategic, so I think Julie kind of mentioned before, to look like how we can maximize that to ensure we're compliant with our provider contracts, as well as leveraging and ensuring we get maximum reimbursement. You'll see here that for DISH, we estimated to be about $633,000. QOF is another estimate, and we're still kind of working to see what that'll be. It has not yet been approved, so we have some values here for now, just to kind of as a placeholder. Again, this is our base revenue, so this is exclusive of any impacts to HR 1. And so we looked at the DISH is one where we see that the amount is fairly low as compared to 2025, and that is a conservative estimate due to the fact that we anticipate, I believe, a 55% cut. It doesn't get repealed as of 10/1 of this year. You'll see here we get a nice pickup in revenue due to QOF, but understand it has not yet been approved, so just kind of keep that in mind as we kind of go through expenses and our final EBITDA. Questions? Kind of points I brought up is our charge master increase of 3%. We saw volume changes. QOF 8 is about 18.6 million in payments. QOF 9 is about 18.5. Again, is subject to change, and so we assume about 75% of the net payments, along with the expenses, just to keep it more conservative, even though it's still unknown if that will come to full fruition.
So just to clarify, the 18.5 for QOF 9 is 75% of what was modeled. The modeled QOF 9 would say that we could get 24.6.
So here again, we calculate our expenses. And you'll note here that obviously labor and benefits is from 2025, again, driven by our volumes. There is a pickup in benefits, and that's due to the fact that we received the quotes for our benefits vendor, and it's about 14% unit cost increase. So you'll see again, for salaries and wages, contract labor, there's a decline due to the lower volume in 26 as compared to 25, but there's a substantial increase in benefits due to the increase. Again, supplies is volume driven, and so you'll see that there in terms of kind of why that seems less than 25. Again, there's a lot here that is based on volume. Other expenses is inclusive, as the note says, of QOF 9 expenses, and that's why you see that balloon as compared to 20. And again, all subject to final approval. Again, all expenses are still undergoing review and refinement. We put inflationary factors at 3.5%, obviously still up for further refinement as we kind of do further research. I did highlight that benefits are increasing by 14.2%, which is pretty substantial. And again, Julie alluded to labor standards, so we're still looking at refining to see where the current productivity may not match where we need to be next year. We need to reassess what those labor costs will be once we kind of get a better sense of what labor standards should be rather than what viewpoint rate was. So you'll see here again, 24, 25, and 26 respectively. 2025, we project our EBITDA to be about negative 17 million. Our budget for 26 is about 5.1, but again, really driven by the fact that our QOF are very favorable. If they're approved, right? So if you even 75%.
of the best case scenario.
That's the case scenario, that's correct. So like I said, the budget as presented is just for our base volumes only. Some initiatives that are still under review and not yet quite incorporated in the budget as presented is the cath lab, looking at the new physicians, the pro forma assumptions under review, kind of how Steve mentioned, kind of reassessing that. There is potential growth for volume to interventional radiology, which I'm guessing is going to be part of that research. Projected growth, hopefully, with MRI, CT, increased volumes because there's going to be more new and more efficient equipment. But again, with new volume comes new expenses. We kind of make sure that we will incorporate both. The HR1 bill has been estimated to be about 4.2 to 5.6, and that's not having been incorporated yet. Orthopedic volume growth, I think Julie alluded to kind of the providers, and new providers expected to grow more, so hopefully bring in more volume. A revisit to the pediatric admissions program, the new intergovernmental transfers, that's not included in this analysis as of yet. And then any strategic partnership funding or expenses also is still to be determined. And once we get that, we'll include that in our budget as appropriate. I'll stop there and do that meeting before 4 time. Any questions? Wish I had a better picture, but if you think about even with off at 75%, the HR1 bill will kind of eliminate that. Use the estimates there. So more work to be done for sure as we refine to kind of get our expenses aligned and ensure that we truly are measuring the volume in our reverse standard.
What is the process by which you guys evaluate requests from departments? This new monitor, once this staffing might happen, where does that fit in here, and are those already in the numbers, or?
That's the part of the refinement, yeah. So we're looking at essentially what the run rate is, kind of what the costs are as based on our run rate, kind of our current volumes and what our current state is with inflationary factors. So the next step is to work with the department leaders and say, here's what your preliminary looks like. What do you feel is one-off? What do you feel like is new in 26? That conversation is coming after that. But we wanted to at least start staking the sand as to kind of what historical run rates are, and then we'll see how it goes.
And I would just add to that, every week at ELT, we are reviewing any staffing requests. And, 99% of the time, it's we lost a night nurse or a night tech, and we need to replace it, and we agree, in order to keep the service up and running. That's likely true. Sometimes there are positions that come through as a new ad, and we really kind of scrutinize, can we afford that now? What happens if we don't do it? What's maybe an additional benefit if we do it? Sometimes, the benefit can be a reduction in overtime because we've got so many people filling a hole with overtime. So we look at things like that. I think when it comes to equipment, we're certainly looking at what funding do we have to purchase equipment, but also what are any kind of ongoing costs that would be associated with having that equipment. And then, of course, is there ongoing or revenue improvement? So is there an ROI on the case? And so we're kind of always collecting those throughout the year and, kind of trying to funnel them to our little, holding place for budget items so that we remember to include them. And then hopefully the kind of stopgap second check there is a director who's living this stuff day to day saying, hey, I don't see my new maintenance contract in there or something like that. I know, because it's happened every year I've ever budgeted, that there will also be the kind of wish list item. I wish I could have, and, we always look at them, we try to tease out the benefit that may outweigh the cost, and, and do we think we should try to incorporate that into the budget? Sometimes we say yes, sometimes we say no. Sometimes you say no, but but as we go into next year, if finances are improving, if something is happening positively, we still may be able to work it in.
Back to salaries and wages, we're projecting less than, and that's a matter of rising the volume. I guess I want to ask, like, how credible is that as a baseline assumption, but I think proven that to be the case, we're reflecting now where everybody's talking about it.
If you will reassess the labor standards, I mean, that's kind of what we think it is, but we really want to kind of see, are we truly efficient, that maybe there could be potentially more savings, or were we too aggressive, and there's really things where we can't anticipate that because the volumes aren't adequate, reduced to amount for the staffing needs. So that's kind of the more refinement to really see if our labor standards are aligned with kind of what we project for labor.
I think if you look at, some of the things that aren't presented here, but that we tend to also look at, I look at almost 1,000 less patient days budgeted for next year. If we go and we do, a lot of times we'll do, what's the salaries per adjusted patient day, or the supplies per adjusted patient day. And so we'll look and say, in this year we're running $2,700 per adjusted patient day. This, is actually saying we're gonna run 2,705 or 2,692, so that's kind of the background gut checks that we do to also make sure these numbers make sense.
Little question, the utilities and solar and or energy efficiency project, are we yet projecting any savings there yet? I know it's still like really new project.
Haven't anticipated any savings yet. I think that's part of the refinement to kind of see what the impact will be from where we are now to 2020.
The LED project will have some savings, and so that's one we didn't list on the initiatives here, but that, as that is being, kind of been implementing now, we haven't necessarily seen the savings, and probably maybe get a month or two of savings this year. So we'll do our best, probably mostly based on the pro forma from the vendor there. Solar is not a project yet. Yeah.
On the increase in benefits, are we going to be able to push any of that onto the shares of costs, and will that increase those?
Yes. Up to the point that the contracts allow, and the contracts differ a little bit there. So some don't and some do allow for that. And that's kind of factored into these numbers. So the 14% already has kind of factored that in. I was going to say one other thing besides the LED savings of an initiative that we will be looking at is 340B, is where we've now got more historical experience under our belt. We've been growing that program. I'll have it both on the inpatient and the outpatient side, so we should be able to project some additional pharmacy savings. Hopefully they keep up with inflation.
I'm really grateful for the IGT and that's a really nice low-hanging fruit that we're into. I have another question. Do we have any questions from our public? Watching? comment in this space, 2026 will continue to be a struggle year for us. We're gonna create added to and lean into our partners all around us, especially our federal legislative partners, and will advocate for things. Perhaps squeezing some things into the shutdown that might really be very marginal level. I just want to acknowledge this is going to be a year ahead. We're going to be asking a lot of all of you. I know we're going to be asking a lot of all of our employees. Just emotionally, it's going to be a challenge. Operational side. Practicing. Good report. Felt like being. Other comments, questions? That's what this has been, and we're ready to adjourn. And I apologize once again. One day when they have actual flying helicopter things. Taxis,